Okay, everyone, so this is part 2 of the Piaget, or sorry, the preschool lecture for Nursing 5120. I'm going to start off here with a little video of Piaget's preoperational stage, which is where these preschoolers are at, so you can see what that thinking is like in terms of not having an idea of conservation, one of those principles. So this is the idea that they're not based, their thinking is not based on logic, it's pre-logic, and it's based on the appearance and shape of things. So this video demonstrates that really well.
Two glasses. Do you think that they have the same amount of juice? Do you think they have the same? Okay. Now we're going to pour this juice into this glass. Now, do you think that this glass has more juice, this glass has more juice, or do you think that they have the same amount?
That one has more.
This one has more, and why do you think that this one has more?
Because it's taller.
Okay, you ready?
Yeah.
Okay. Does this row have more quarters? Does this row have more quarters, or do they have the same?
1, 2, 3. Wait. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. They're all the same.
They're the same?
5, 5.
Okay. Okay. Does this row have more quarters? Does this row have more, or do they have the same?
This one has more.
That one has more quarters?
Yeah.
Why does this row have more quarters?
Because it's more far away.
It's more far away?
Yeah, it's more far away than like that. Looks like bigger.
Alright, we're going to play a game with the graham crackers, and we're going to share them between me and you, okay?
Okay.
Okay. Do you think that we shared those fairly?
No.
No, why not?
You have those and I have this one.
Well, what if we try this? Okay, can I put this down right there?
Okay.
Now is it fair?
Yeah.
Yeah, why is it fair now?
Because we both have two.
So that's just a great little video to refresh you on some of that idea of Piaget's preoperational thinking. Oh, why did this not go? There we go. So based on, from what we know from Piaget earlier, the other thing is that it's best to tell a kid of this age group about a new sibling when the pregnant parent begins to show, so that there's concrete evidence of that change happening. It's not an abstract idea. So for families who are adopting, or families that are being reunited after a separation like immigration, or it's when the preparations are starting to make space for the newcomer or newcomers. So often this encroachment of other people, whether it's a new sibling or other extended family members into their space in their house, leads to jealousy, which is a common emotion for people through the lifespan. And it's a response to that actual or supposed or threatened loss of affection. And it's a really common emotion for everyone, and it can be rooted in fear or anger. And so jealousy of a new sibling is really strongest for children under 5 years, because they see that, just as we saw that little girl with the graham crackers, they see time as this thing that they had all of it before, and now this kid is taking some of it, and they don't really see how it's not divided up, or that a parent doesn't love them less because they're getting less attention or getting attention in a different way. And so they try to get those attentions then by reverting back to behaviors that they might have expressed at an earlier stage. And they might also be outwardly aggressive, so biting or pinching. Um, and so these kind of behaviors are seen less in kids who are either only kids or kids who have a wide age gap between siblings. There's less direct peer-to-peer conflict if there's a wider spread in ages. So one of the ways, these kids are industrious and they want to help and they want to please people. So giving them a new role of being a helper with the sibling, or being really well behaved, and entertaining themselves quietly if they're not interested in helping, are two really good ways that these kids will really tap into. So encouraging a 4-year-old child to assist with the care of their newborn sibling, brother in this case, will assist in his or her adjustment to having a sibling. True or false? And as we were just saying, it is true. Some introverted children, though, is part of that personality. So more introverted kids might not want to be a helper so much, especially if there's a performance aspect to it in front of groups of visiting people who are coming to see the new baby. That can be too overwhelming. So being industriously quiet and producing something like a picture for someone who's visiting might be a better tactic. But this idea of being a helper is really, lots of people have found it to work really well, and it fits with the developmental stages. So thumb sucking is a big issue that parents get concerned about. It should, I mean, it's an instinctual behavioral pattern, as we've said. It can be part of that regression. Sometimes it can be semi or subconscious, so happening at bedtime as a soothing mechanism to help a child fall asleep. There's really no detrimental effect as long as permanent teeth aren't starting to grow in. Permanent teeth are so malleable, they can be pushed around in the mouth really easily, and so that can lead to misalignment of the bite. So encouraging the desired behavior again is one of the best approaches, but it may regress in periods of stress or fatigue, like, hospitalization. So therefore also making sure hands are really, really clean, but also encouraging the positive behavior of not sucking on their hands. Giving them stuff to do with their hands will keep those hands out of their mouth. Bedwetting is also a biggie, and it's prevalent right through. It's typical for kids to wet the bed at night up to age 4, and that's a range. Really, 4 is kind of the average, so up to 5 years is even not really considered out of the norm. So primary bedwetting is when the child has never had a night's sleep that's dry, and secondary is when it recurs after they've already been dry for a period of 1 year or more. There's lots of evidence to show that it's more common in boys than girls, which has a lot to do with sleep patterns and all sorts of things. There's lots of different reasons out there for it. And there can be organic causes that need to be attended to by primary care practitioner, like a family physician or a nurse practitioner. And that include urinary tract infection, diabetes mellitus, which is typical pancreatic diabetes. Diabetes insipidus is nothing to do with the pancreas and everything to do with pituitary gland, which regulates fluid control in the body. And so this disorder is seen with pituitary dysfunction, pituitary tumors, other brain tumors in proximity to the pituitary gland, or with basal skull injuries. There can also, so I used to see diabetes insipidus about 2-3 times a year in neurosurgery patients, whether they had an injury or had had a brain tumor removed. It can have either, it can have excessive thirst and excessive urinary output. Also, in rare cases, some kids just refuse to drink, and so with some advocacy, they can end up with a tube for fluid and food fluid ingestion, because they'll just refuse to drink, and then they'll get dehydrated. They can also have bedwetting can also be a result of seizures that can cause different spasticities and relaxations of various muscles on the body. So that can include the two sphincters for urine control, as well as obstructive uropathy, which has to do with the ureter that connects the kidney to the bladder, and abnormalities of the urinary tract. So dysfunction in the tubules in the kidney, which resorb fluid, can cause lots and lots of urine output, as well as sleep disorders. So deep sleeping, active sleeping, where the body isn't like immobilized, can lead to, so acting out of sleeping or acting out dreams can lead to incontinence at night, or enuresis is the proper word for nighttime voiding, enuresis. So data collection and considerations would include how they're doing on their developmental milestones up to this point, including toilet training. If there's been a pattern of bedwetting in the past, how many nights or times per week are they bedwetting? What's their usual stretch for staying dry? How much do they pee during the day? How much do they drink? Would be, oh yeah, so it's coming up. The type of stream, so is it punctuated, like stop-start, or is it a steady stream, and is there urgency when they finally do have to void, or are they the type of kid that can say, yeah, sure, I'll go try and pee, and then pee, versus playing, oh my gosh, I have to pee. The amount of fluid taken between dinner and bedtime, family history, is there stress going on, family fighting, that kind of thing. Sometimes a typical pattern is for parents to be angry at each other about something and wait until after the kids have gone to bed. Well, if that's the case, then a child who has to void might be too scared to get up to pee, so it falls asleep and can cause bedwetting, as an example. But other stressors like being in the hospital, having an IV, also urinary tract infections or dysuria, and some medications, it's a side effect. So not nighttime bedwetting, but just higher voiding generally, which then leads to enuresis. So the kid needs to be involved and be the center of the management program as well. Liquid should be limited after dinner. Kids should be encouraged to void before going to bed. There's counseling and hypnosis options. There's behavior modification things, so different types of gizmos for the bed that set an alarm with just a little bit of fluid, and so that wakes people up. Bladder training exercises to increase and stretch the bladder size. And yeah, I think I've covered that stuff. So preschool, these promote readiness for higher levels of schooling because they're incorporating structured activities and cooperating in big groups, and coping skills, self-management, because you're sort of diluted over a bigger group now than you probably were at daycare, where there might have only been 6 or 8 kids in your group. Now there's going to be 15 or so in a play school group, or a junior kindergarten group, 15 or 20 even. So they're going to gain self-confidence, positive self-esteem. So one of the things that's available in the supplemental resources that you need to have a look at is the expectation for kindergarten for curriculum. And it's a brief little 2-pager, like it's nothing major, so there's no excuse not to go have a look. Please, that'd be great. Thanks. Daily care. So kids don't require extensive physical care. I think your textbook said something crazy about like bathing every day, which sure, awesome. But if that's part of the routine and it helps a kid relax and sleep, and splashing around in the water makes them feel like they need to then go pee because they've been sitting around in warm water, then perfect. That's awesome. That can be a lot of time in a bedtime routine, especially with multiple kids. But so washing up each night should be part of the routine, whether that's washing at the sink with a face cloth and scrubbing your face and ears and neck and underarms, and then bathing several times a week and shampooing their hair a couple times a week. Clothing should be loose enough to prevent restriction of movement and to enable toileting by themselves. If they're not able to get out of their clothes by themselves, then they're going to have a really hard time learning how to go pee by themselves and get back dressed up again. Even if they need help cleaning up after using the bathroom, still being able to facilitate doing that part independently is going to go a long way towards toilet training. And then sturdy, supportive shoes. Because of those growing bones in those feet. So making sure they don't have restrictive shoes at that age, and which allows activity as well. They all build on each other. So if families can't afford stuff, it's up to healthcare people to kind of tap in and noticing toes poking out of sneakers and things like that. Do you need assistance with this stuff? That kind of thing. Accident prevention, again, accidents are a major cause of injury and death in this age group as well. Car safety is essential. Like it's a like absolute non-negotiable to be buckled in the car. Again, burns, I think I used this as an example in the previous video. Kids exploring what's hot and what's not, but needing to understand that lots of different things are hot, and experimenting with taps, making sure that perhaps suggest to parents that the water heater in the house actually be turned down, both in infancy to prevent scalds, accidental scalds, and toddlerhood, and preschool, as well as poisonings. Kids are more interested in getting into things, and so things like cleaning crystals also look a lot like a lot of different candies, like a Pop Rocks type candy and that kind of thing. So restricting access to those within the environment, locking up medications, that kind of thing. My sister used to have like the medications in a weird place in the pantry, locked in a lockbox on the wall, so that it was, if the adults needed Tylenol, they could go to the fridge magnet that had the key for that and go and get them. But my nephew certainly couldn't figure all out the steps that would require him getting at something like Tums, which is pepperminty and seems like candy, but shouldn't be taken in heaps and heaps of amounts. So as well as talking about the dangers of getting in a car with strangers, this wanting to please people thing can put kids in some dangerous situations. And the dangers of playing in secluded areas, as much for the stranger thing, but also just in terms of their own personal safety of getting hurt or injured, and not being able to get help from somebody because they're someplace secluded. Just in terms of the dangers of talking to or getting in a car with strangers, bear in mind too that the vast majority of sexual assault and sexual interference with minors is by people that the child already knows and trusts. So facilitating that sexual development and open sexual communication and using the proper words, or using words that are specific, help with kids then communicating to trusted people that something happened that made them feel not good. If you use a generic word like vagina, that it means the entire bathing suit area, or pee-pee, that means every part of or the area around the penis, testicles, and even the bum, then if somebody has interfered with that kid, has assaulted them, then that language might not raise red flags for people. As well, in terms of safety, indirect supervision is necessary due to poor judgment. So this means creating those limits, but then also making sure that it's safe. So this can include letting kids who are 5 years old go outside in a yard with kids who are older, but then having adults who are nearby, like in a side yard or sitting on a porch or in a room that's adjacent with a large window to that backyard space, so that they're still being indirectly supervised both by the older kid and also by the adults who are nearby and reachable in case something goes wrong. So in terms of health and illness, play during health and illness is important all the way through, whether they're healthy or they're not well. So it's important to their physical, mental, emotional, and social development, and increases communication with other children. The nurse's role is to include play in the plan of care, and there's a series of questions on the last slide that I'll get to. Factors to consider: their state of health, overstimulation and fatigue, and diagnosis considered when choosing toys for the child. So this next slide goes into that a little bit in terms of play being non-competitive. This is going to help any child, healthy or well, adjust to the expanding world with increased independence. So looking at play for someone with a developmental delay, there was a girl I remember taking care of at CHIO who had profound developmental delays, so that her mental age was very different than her chronological age. She was about 9 years old, but really had the mentation of someone who was at about 7 or 8 months. And so with her, she was really reactive to sensory stuff in her environment. And you could talk to her and she could understand some words and her name, and she liked songs that she was familiar with, but she could get really bored of that stuff really quickly. And so we were always looking for new sensory things. So that included putting crumpled up pieces of different textures of paper into a box and letting her explore a box full of crinkly papers and construction paper and regular paper and tissue paper, and she could pull those out and rip them up and feel how they're different. It created a mess, but it's just paper. Similarly, we took a bowl and emptied 2 containers of Jello into the bowl, and so the Jellos started in the shape of the containers that we dumped them from. So she had 2 blobs, and then she squished them around with her fingers and broke them up into smaller and smaller pieces and played with splashing with it. And she had limited vision, so it was more her sensory use of the Jello, and played around with it till it was almost liquid. And of course we planned that for right before it was bath time. So she did that. Man, she played with that for like 20 minutes to a half an hour. Like, it was pretty spectacular, just squishing her fingers through that Jello. And so that's that difference in mental versus chronological age. And repetition of play experiences is necessary throughout this age and stage. They'll want to do the same activity or read the same book or sing the same songs over and over and over again, and which is great because they're learning and training themselves and seeing different things in it every time. So therapeutic play is play that is fun for kids and age appropriate, but it's helping to do something that's an end in itself for the healthcare provider as well. So whether it's retraining muscles or improving hand-eye coordination or helping kids to crawl and walk. So an example would be like any blowing activity after surgery to help those lungs re-expand after a kid's been intubated. So we used to do things like I mentioned earlier, blowing out the flashlight as if it were a candle, which kids think is like magic or something. Or if they're old enough, they think it's a joke. They get it, that you're flicking it on and off, but they'll still do it. And So you can pretend, if you get them to draw a picture of a flower, then to breathe in nice and deep, they take long, slow breaths in to sniff the flower, and then they blow out to blow the candle out, and you make them blow as long as, oh, you almost got it, you almost got it. There you go, and then you flick the flashlight off. The other thing is that kids have to get up and walking after surgery, even though they're uncomfortable and pain. So whatever you can do to make that fun is part of therapeutic play as well. So one thing I remember doing, because I liked goofing around with kids, is dance party games. So if they weren't well enough to dance, well, I'd dance, and mom or dad or some other caregiver that's their siblings might dance with me, and then we'd start a dance chain down the hall. We had to, whatever the goal was. And so sometimes kids would reach the goal, but they're having enough fun dancing or watching us make fools of ourselves that they'd want to keep going. Or having the child who'd had the surgery call out things that we had to walk like. So if they wanted us to walk like a duck or hop like a frog, or we drew the line at things like slither like a snake because it's the hospital floor, gross. But yeah, those kind of animal games as well. And then play therapy is different again in that it is used for kids under stress. So it helps kids play out their fears, whether it's using dolls or puppets or that kind of thing. And so you might use that in preparation for procedures. So showing a child on a doll or a toy what the procedure is going to entail. And then art therapy is means of communication between child and adult used to express feelings and communicate through drawing, clay, modeling, or other forms of art so that kids can express feelings and communicate through that artwork and tell the story of that art that then allows them to tell the story that they need to. And then engaging imaginary playmates is one of the nursing tips in your textbooks. So either doing the action on the imaginary friend first, whatever you need to do for a procedure, or asking what the imaginary friend is scared of, and the kid is going to tell you what they're scared of. Okay, so I have just a video here. Oh, come on. Stopped cooperating with me briefly. Of how this therapeutic play comes in at CHEO. So here we go.
Blood work and other medical procedures done at CHEO can be nerve-wracking for kids and parents alike.
That's where CHEO's child life specialists come in. They're trained to help prepare patients for what's going to happen to them, making sure their experience at the hospital is a positive one. Here's CTV's Claudia Cotillo to explain.
Let's go to room 11. We're going to go and get her pentamidine.
Like most kids in CHEO's medical day unit, 7-year-old Abigail needs blood work.
This is it. Hello.
She's being treated for cancer.
Oh, it's hard. You can do it.
For many kids, blood tests can be intimidating.
It doesn't hurt.
Child life specialists at CHEO, like Manon Rollin, are here to help.
So we will use a lot of play. We'll actually teach and prepare kids for their medical procedures that are coming up.
Let's go for the good spot. We only won one poke.
So we'll do a bit of medical play. I have what I call like a Caillou doll. And so we'll go through the different steps and sometimes explain why we need to do that.
You can actually get the syringe at the end and then twist, push, and twist.
Doing mock procedures like blood tests and putting in an IV help patients understand and feel comfortable.
I need to unhook it.
11-year-old Ryan is another one of Roland's patients. He's also receiving cancer treatment here at CHEO.
She brings video games.
Yeah.
With the help of child life specialists like Roland, he knows what's in store, even has some advice.
Say 3, 2, 1 slow before you put the needle in. Don't look at the needle when they're putting it in.
What's going on? Is there something hiding?
Yes.
Even on the tough days, Roland loves what she does.
It's an amazing job.
She's been at it for 17 years.
Obviously, there's hard days working on the oncology MDU unit. There's days where there's like new diagnosis or patients who've relapsed.
But she says the kids and their strength keep her going.
They're all heroes, you know. Some of them go through a lot, and you never hear them complaining.
Rollins says her patients teach her too.
They're living in the moment, so I think that's a big lesson for us adults.
Your fingers almost got stuck in there? Yeah. Oh, now Ryan.
Because we let kids be kids, and so we can leave the illness behind and just move on with the serious kids' business, play.
Claudia Cotillo, CTV News.
All right. And nurses and child life therapists work very closely together. All right, so for nurses, the implications of this largely has to do with the idea of hospitalization or even going to the primary health care clinic and seeing the physician or the nurse practitioner is stressful and it can be scary. Kids can see the procedures or the actual hospitalization as a form of punishment, and kids might feel abandoned. And so both whether it's stressful procedures or whether it's that kids are going into being hospitalized, separation can be helped by having parents bring comfort items, so favorites, whether it's a favorite blanket or stuffed toy, security items, or even a favorite t-shirt or a favorite part of a costume, a Halloween costume, that kind of thing, can all help kids to disengage from some of that reality stuff and focus their attentions on those well-loved items. Parents can also room in at CHEO and at sick kids, and they should be encouraged to do so, as well as provide for their own needs for rest and comfort. So, and parents who are staying and helping with care for their kids, or continuing the care for their kids that we're helping them with, rather, they should be encouraged to keep up the bedtime rituals as much as possible. So then helping them anticipate interruptions in the routine, like doing vital signs in the middle of the night, might then mean that little mini routines have to happen. So that needs to be arranged sort of before it happens, like letting families and kids that anticipatory guidance stuff again. Let them know, I'm going to be waking you up at midnight and at 4 in the morning to do these vital signs again. What should we do at that time? Should we sing Twinkle Twinkle is your bedtime song? Great. Should we sing Twinkle Twinkle over again? Because we're not going to do all the stuff. We're not going to brush your teeth, and we're not going to read 3 stories, and we're not going to do all those things. But maybe going to the bathroom and singing Twinkle Twinkle can be the middle of the night routine. So just shortening that, but still encouraging that routine to help settle kids and go back to sleep. So the stages of separation anxiety include that protest, so pushing away and perhaps reverting back to almost temper tantrum-y behaviors or even full-on temper tantrum-y behaviors, and then despair where they're completely inconsolable, detachment where they're disengaging from the people that they're left with, and potentially regression to earlier behaviors. It might take a few sort of going through these cycles and realizing that actually no, mom and dad or my parents and caregivers come back and I'm fine, and I'm capable of dealing with this stuff, for kids to kind of get over that eventually, or situationally anyway. So these are those questions, the nursing assessment questions, both by asking parents or caregivers, but also observing the child. So what's the child's approach to play? Are they outgoing and run right into the middle of everything impulsively, or do they linger outside the group and are observational and maybe hang back a little bit? is that from anxiety or just because they're analyzing stuff? Are the kids actually that run in impulsive, or are they just really outgoing? Does this child prefer active or quiet activities? How are they with stimulation? Are they easily overstimulated? Can they settle back down again if they've gotten all super active or hyper? How quickly do they settle back down again? Is that the same if it's anxious behaviors? Can the child talk with his or her playmates and convey ideas? Or with adults, how are they with doing that same communication with them? And what kind of attention span does the child have? So bearing in mind that at 3 years it's about 15 minutes, at 4 years it's about 20 minutes, and by 5 years it's rocketed up to a half an hour. So if you guys have any questions, I didn't put my email in here, but I will. Oh, there we go. So it's Carol, 1L, Carol J at algonquincollege.com. So feel free to email me as needed for any questions that you have from these 2 videos. Thanks.